Thank you very much. I'd like to thank Dr. Mello and Rodrigo for inviting me here this weekend. It's been a fantastic trip, and I'm excited to talk about a topic that I'm very passionate about, that being the ACL injury. And on this topic, we'll talk about ACL injury prevention and review what the current evidence suggests. The current literature is replete with evidence which suggests that female athletes are 4 to 6 times more likely than their male counterparts to suffer an ACL injury, which makes them a perfect model to examine the efficacy of ACL injury prevention. So the first question we must ask is, what are the theories behind why females are at greater risk? And the literature, again, very clearly states that there are structural and anatomic theories, hormonal theories, biomechanical and neuromuscular theories. Because we're talking about injury prevention, we're going to focus on more the biomechanical and neuromuscular theories. So now the question is, why does this young female athlete, when she lands from a jump, which she's done many, many times in her career, why does she suffer an ACL injury in this position? So we must ask ourselves and focus more clearly on what the injury mechanism is at this point. And the literature would suggest that an at-risk position, including knee abduction, low knee flexion, landing on a single limb, and landing with the foot away from the center of mass, may increase the risk of injury in these young female athletes. Malinczak, over 10 years ago, did a very nice study comparing the kinematics and EMG data in both males and females during running and cutting maneuvers. And he started to bring to light some of these at-risk mechanisms, including low knee flexion angles, increased knee valgus, greater quadriceps activation, and a decreased hamstring activation in female athletes during these tasks. And if we think back to that picture of the young lady tearing her ACL, many of these mechanisms were evident in that picture. More recently, in a study done in our lab in 2005, we prospectively evaluated biomechanical measures and postural stability in young, healthy female athletes before they participated in soccer and basketball. So we had 205 young female athletes come into our lab. We executed a biomechanical analysis and then had them go out and participate in their sports. And during the season after the biomechanical evaluation, 9 of those 205 athletes suffered an ACL injury. And from that, we were able to develop predictive models of what caused these young female athletes to go on to ACL injury. Some of the most impressive data suggests that side-to-side differences in vertical ground reaction force, which is seen here, and a decrease in the speed at which these loads were exposed on these young athletes was a predictor of injury in young female athletes. Probably the most notable, and the one that's been written about most frequently in the literature in the last 5 years, is knee valgus, or the knee valgus angle. This represents a scatter plot of the knee valgus angle of all 205 athletes who were involved in our study. The red X's represent the 9 young female athletes who went on to have have an initial ACL injury. And I think you can appreciate there seems to be a dichotomous representation here. There's a group up here which lands in a more adducted position, and then a group down here which we would consider at risk in a more abducted position. This young individual down here would certainly be at the greatest risk, and I'd hate to be that person right there. Again, we see representation of knee abduction at initial contact. The group that had an ACL injury struck the ground in an abducted position versus the uninjured cohort. And the group that, and when we looked at peak knee flexion, the group that went on to have an ACL injury also had a decreased knee flexion. So again, some of the things that we were suggesting in our mechanism and that Malinczak initially looked at over 10 years ago. So as we move forward in the literature, we start to see greater evidence suggesting what the mechanism is in this young female athletes. One being video analysis. 2 studies which were published between 2004 and 2006 noted through video analysis that typically female athletes were in this valgus collapse position more often than males. They tended to land on a single leg. Oftentimes their foot was planted away from their trunk. They had decreased knee flexion angles, and many times there was an unanticipated perturbation of the trunk, all of these feeding into this high-risk position. And then most recently, in a study in 2007 by Zazalak, this group of investigators notably looked at the position and the importance of the trunk. And what they did was they prospectively looked at core proprioception, so how these athletes were able to determine and perceive the location of their trunk. And what they noted was that the young female athletes who had poor core proprioception or didn't have a good appreciation of the location of their trunk during a task where the rest of their lower extremity was stabilized, they actually had a much higher rate of ACL injury and general knee injury. So this position of dynamic knee valgus, so in addition to having a trunk out of the center of mass, seems to be the high-risk position, which creates increased vulnerability in our female athletes. So the next step, now that we've identified what the mechanism is to identify what parallel neuromuscular imbalances exist, which may be able to target some of these at-risk mechanisms. And the ones we'll talk about are ligament dominance, quadricep dominance, and leg dominance. Ligament dominance has been defined in the literature as the lack of dynamic muscular control in the medial lateral direction, resulting in increased valgus stress on the ligaments. And we see here in this video representing a young female athlete going into that at-risk valgus position, or in a more ligament-dominant position, versus our male subject who tends to jump with a more muscle-dominant position. The second mechanism being the quadricep dominance asymmetry, or a preferential activation of knee extensors over knee flexors during athletic maneuvers. And this has been identified in the literature over the past 10 to 15 years. The last dominance is side-to-side differences, or leg dominance. And this is the preferential activation, or the preferential favoring of one limb versus the other. And in the case of a young, healthy athlete, oftentimes they favor their dominant limb versus their non-dominant limb. So now that we've addressed the mechanism, we've tried to identify what the mechanism is which causes this ACL, young female athletes to be at high risk for ACL injury. We've looked for parallel neuromuscular imbalances. Now we want to try to address the mechanisms from a knee abduction perspective, trying to address the biomechanics and techniques of their jumping and landing. For someone who lands with a low knee flexion angle, trying to address the ham-quad ratio and recruitment. For someone who has issues with landing on a single limb, maybe we can address balance and improving symmetry of motion. And finally, for someone who tends to land with their foot away from their center of mass, or who doesn't have control of their trunk within their base of support, maybe addressing more core stability. But where do we start? We can't just indiscriminately apply these interventions to this mechanism without exploring the literature. And if we look at the literature over the last 15 to 20 years, there is a tremendous amount of literature. When we look at last I did a PubMed search on anterior cruciate ligament, there was over 8,000 citations. And if we looked at ACL and prevention, still more than 400 citations. So much too much literature to examine in a few moments here. So what I chose to do was look at one of the highest level of evidence, being a systematic review and a meta-analysis, which was published between 2004 and 2006 by Hewitt et al. And within this study, they were able to identify 6 published studies which tried to target ACL injury and prevention in female athletes. It tried to look at the relative effectiveness of interventions and looked at the commonality of training programs between these different groups. The search terms that they used, I'll quickly review, were being knee injury and sports injuries, intervention and control. They only looked at randomized control trials or prospective cohort studies. And finally, they had to have a neuromuscular intervention designed to decrease ACL injury. And when they looked through these articles, if they had these 4 key terms, then they were included in the study. And there were 6 studies which were identified. And I'll lead off by saying 5 of those 6 studies concluded that neuromuscular training and neuromuscular interventions had the potential to decrease knee injuries in general and ACL in particular in athletes. So if we look at a forest plot of this data, we see that when we do a meta-analysis of the data, it does favor treatment to decrease ACL injuries in these young female athletes. So let's look at each of these 6 studies individually before we collectively look at what these findings suggest. The one study was published by Hewitt et al. In 1999. They had a very strong prospective cohort design, and they looked at 43 high school teams, 30 females and 13 males. They did a very rigorous program. It was a preseason program. It was a 75-minute neuromuscular training program that went on 3 times a week for 6 weeks. These authors reported a 72% reduction in the rate of non-contact ACL injuries. In 2000, Height published a study in AJSM. It also was a prospective cohort design. It was a much smaller study, though. Only had 42 participants, so much smaller group, probably only 1 to 2 teams. They only did treadmill speed training and foot agility training, so didn't do any plyometrics, which was suggested in the Hewitt study. They also did a very intense program of twice a week for 7 weeks and noted a reduction in injury, but did not have an effect on ACL injury rate. Soderman in 2000 did a randomized controlled trial, a very strong study design, on 140 professional female soccer players. Their intervention, though, interestingly, was only a home exercise program of balance training. So they had a very unidimensional program of balance, and it was all with home exercise, so no reporting of compliance in this group. They also did a 3 to 7 times a week in-season program, so it was both before and in season, and they did not notice any differences in ACL injury rates. Mickelbust in 2003 did a very strong prospective cohort design study with a huge cohort, over 2,600 female team handball players over a 3-year span. They had a hybrid approach. Their approach was not only in-season, but it was a preseason and in-season program, which included a very diverse program of balance, plyometrics, and jumping and landing skills. And they also saw a significant reduction in ACL injuries. Mandelbaum in 2004 published their controlled cohort study of over 57 young female athletes. Their program was strictly in season. They didn't do any preseason program. It was only about a 20-minute program designed to replace the typical warm-up that the soccer team did, and they had a 74 to 88% reduction in ACL injuries. Peterson in 2005 did a prospective case control study with only 236 female athletes, so again a very small cohort in this example. They only did balance training and plyometrics, and they saw an 80% lower ACL injury risk. However, this change was not significant, suggesting that they were underpowered with their sample size. And finally, Wetterkrop in 1999 did a randomized control trial of 237 female handball players utilizing balance training and whole body warm-up prior to their practice in game, and they also saw a reduction in overall injury rate. So if we summarize those articles, we see the majority of these, 5 out of 6, did demonstrate a reduction in injury rate with some type of intervention. And again, the forest plot, which we saw previously, when we do a meta-analysis of the data, does suggest an overall favorable effect. So theoretically, what this is suggesting is that if neuromuscular training can increase neuromuscular control of the joint, can decrease knee and ACL injury risk, and then the mechanisms underlying these may in fact be neuromuscular in nature. So let's look at what some of the commonalities are, because the interesting thing to note is that 5 out of these 6 studies reduced general knee injuries, 4 out of the 6 reduced knee injury risk, 3 of the 6 reduced ACL injury, but they were very different. It was a very diverse mix of programs. They were not similar, which begs the question is what's the common thread that lives between all these programs which may provide an efficacious intervention to decrease ACL injuries. So I'm going to break down these programs into these 6 components, being landing training, balance training, plyometric training, technique training, core stability, and strength training, and look at each of them individually and see how they were different or similar between programs. And in general, we can say that the effects of the 3 programs which did demonstrate a reduction in ACL injury seem to be rooted in the same theory of trying to not only improve performance of these young athletes, but also working from a physical rehabilitation standpoint as well. We'll first talk about landing and balance. So what oftentimes was used as an intervention is plyometric training. So plyometric training, in addition to biomechanical analysis and technique training, were common components of the 3 studies that reduced ACL injury rates. All 3 of these studies that incorporated plyometrics did also show ACL risk reduction. And in addition, all 3 of the studies that did not incorporate these plyometrics did not reduce ACL injury risk. The plyometric component of an exercise intervention does have the opportunity to train the muscles and connective tissue, focus on proper technique, probably and most importantly working on technique, and reduce potentially serious injury risk. The training interventions that incorporate in plyometrics, again, if we focus on technique, we're focusing on controlling these varus and valgus positions and trying to work on developing a more muscle-dominant pattern and trying to recruit the neuromuscular control of the lower extremity. What about technique? The studies by Hewitt, Mandelbaum, and Michelbust all incorporated technique analysis and feedback, which was beneficial in this design. The 3 non-effective studies did not have any type of technical feedback. The interventions that only did balance, so if we focus on balance now, some of the interventions only looked at balance, and they were not effective in reducing injury. Interestingly, Wetterkrop was effective in reducing overall injuries, but not knee or ACL. The interesting thing to note with that, again, is that balance training alone may not be sufficient to produce significant knee and ACL injury prevention effects. When we think back to some of the original literature on ACL injury, though, it's interesting to note that balance training alone, although not proving to be an efficacious intervention in isolation in females, was an efficacious intervention to reduce injury risk in young males in the Carafa study in 1996. This may suggest that there may be different injury prevention interventions which are needed for different genders. When we look at balance and core stability, the studies by Hewitt and Mandelbaum did incorporate core stability and balance training, and these two were efficacious in reducing ACL injury risk in female athletes. We look at single leg stability, was gained with balance during these training effects, and these findings did support the integration of proprioceptive stability and balance training when we look at ACL injury interventions. Well, what about strength training? Because previously some studies suggested that strength training was necessary to get injury reduction and output. But in fact, the studies by Hewitt and Mandelbaum did incorporate strength training. However, it wasn't necessary to see a reduction in ACL or knee injury risk in this cohort. Therefore, we can come to the conclusion that, at least from strength training, that although it was beneficial, it was not necessary to reduce that injury risk in female athletes. Well, now that begs the question, what about the intangibles? Because there's other variables which we were not able to look at, such as what are the differences between a preseason program versus an in-season program versus some type of hybrid program. In addition, what about the variability in the intensity and frequency of the program? Because some programs were only 10 minutes before practice, while others lasted 75 minutes for many days in the preseason. And will this type of intervention work for male? At least from the balance study findings, it suggests that there may be different interventions which are more appropriate for males versus females. So there's still much to be investigated in looking at the most appropriate intervention to decrease ACL injuries. So as we summarize this, these studies do provide good but not unequivocal evidence that neuromuscular intervention training is likely to be an effective solution to the problem of gender inequity in ACL injury. So selective combination of neuromuscular training may provide additive effects and further reduce these ACL injuries in female athletes. But certainly, additional research is needed to assess the relative injury risk using these mass neuromuscular screenings, looking to see if there's a better intervention that we can implement, not only in females, but also in male athletes. So the ultimate goal is to try to predict high-risk individuals. If we can identify young female or male athletes who are at high risk, try to screen them and identify them, appropriately train them in targeting interventions which have been gleaned from their screening, and then hopefully prevent future ACL injury as we see here. I'd like to acknowledge Dr. Hewitt, Ford, and Meyer, who are the impetus behind this study.